the Center for Interdisciplinary Health Workforce Studies 2015 Fall Webinar Series that focuses on value-based care and the implications for the health workforce, particularly the nursing workforce. We are pleased to have all of you joining us for today's webinar. A few center announcements before we get started and show today's webinar. First, we have posted second quarter RN workforce data to our website that details the most recent employment trends for registered nurses. Please visit our website for more information at healthworkforcestudies.com. Second, center researchers David Auerbach, Peter Bierhaus, and Douglas Steger have just published a recent article in Medical Care forecasting the size and age distribution of the nursing workforce and comparing our forecast to demand recently projected by the Health Resources and Services Agency. These are important findings that suggest while these shortages are not as dire as previously projected, we will still face challenges to meet future needs. We have a write-up with links to the article available on our website. Please feel free to post and share this information with your networks, colleagues, in newsletters, and on your social media accounts, websites, etc. Finally, we will be releasing some trend data briefs on other professions, including physician's assistants, physicians, over the month of October and November. Be sure to check out our website in the coming weeks for more information about that data. Now shifting to today's webinar. We intend to allow for discussion time of about 15 to 20 minutes after our speaker concludes her presentation. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many as we can. We are also recording the webinar today, and we'll have it posted to our website. And we have posted all of the previous webinars to our website, including last month's value presentation, if you missed any of our previous events. You can also find presentation slides posted within the event calendar as presenters allow. Today we have a great presentation focusing on value-based care and implications for the nursing workforce. I would like to allow Peter Bierhaus, Center Director, to take a minute to share more information and then let him introduce our speaker. Peter?
Hey, thanks, Christy. Good to hear your voice back in Nashville. And I'm coming to you live from our studios here in Bozeman, Montana. It's sunny today. The temperatures will reach the low 70s, and there's still no snow on the nearby mountains. But all of that aside, Christy mentioned the article published recently in the journal Medical Care, and I'd just like to note two things about that article. The first is that these forecasts that are published now suggest that we are likely to replace the more than 1 million registered nurses who today are over the age of 50 years of age and are expected to retire over the next 10 to 15 years. This is really important and good news that we do expect to be able to replace these retiring nurses. Now, second, even though we project a growing supply of RNs, when we compare our supply estimates to the recent demand forecasts published by HRSA, we cannot rule out the possibility of a shortage of registered nurses of approximately 125 to 130,000 nurses by the year 2015. So we're making good progress, but we're still not totally out of the woods. More on that as you look at the article and take a look at that. The second thing I want to comment on is that something Christy mentioned with the posting just the past day or two of the second quarter 2015 estimates of employment growth of registered nurses in the country. Now, this is data shows that RN employment, once again, for the second quarter in a row, shows a substantial increase in hospital employment, while at the same time declining employment in non-hospital settings. It's an interesting and curious picture that we're beginning to see through mid-2014 through the current second quarter 2015. Now finally, before I turn things over to Olga, I want to just let those of you who may have not heard the most recent webinar a couple of weeks ago that was given by Dr. Rich Lindruth at the University of Colorado. Now, his presentation is posted on our website. You can find it there. But Rich got our webinar series on value started off with some great background information and ways of thinking about value, and particularly the perspectives of society, of organizations, and of patients. So there's a lot of rich material in Dr. Lindruth's presentation. It's a great setup for today's presentation. Now, that presentation will be given by Dr. Olga Yakosheva, who is an associate professor of nursing at the University of Michigan. Olga's research is in the areas of health services research and health economics. Olga focuses on nursing in both acute care and social network analyses. Now, her work on nursing examines the role of nurse from a human capital perspective, and particularly as it relates to the ability to reduce hospital costs, reduce mortality and readmissions. And her findings are starting to be shown everywhere, but you can look in medical care and in health services research and other journals for her most recent publications. What is unique and very fascinating about Olga's research is that her social network research examines how an individual's decision-making regarding his or her health is impacted by the social environment. And it has been, again, published in leading economics and other journals. And so I encourage you to take a look at those. She did her postdoctoral training at Yale University School of Medicine, and Olga received her PhD from the University of Illinois. She holds an MS, or Master's of Science degree from the University of Illinois, and a bachelor's degree from Kazakh State University. I'm not sure I said that right. So Olga is going to describe value-based purchasing initiatives and how they will influence the value of nursing care. She's going to highlight evidence on where policy has been successful at increasing value and where there is an importance and where it is important for further improvement. Olga, thank you very much for giving today's webinar, and I will turn the microphone over to you, broadcasting from Ann Arbor, Michigan.
Thanks, Peter. Thank you for the very generous introduction, and thanks for having me. So the title of today's talk is The Role of Nurses in New Incentive-Based Hospital Payment Models. So the talk will focus specifically on hospitals and incentive-based models that are targeting hospital performance. As we all know, healthcare reform is placing an increasing emphasis on reimbursing hospitals based on the value of services that they provide instead of the volume of services provided. And so over the course of the next 30 or 40 minutes or so, I plan to share with you some of the approaches to leveraging nurses in improving hospital performance, now that hospitals are increasingly finding their reimbursement payments tied to performance metrics. After providing a conceptual foundation, I will focus on describing the value-based purchasing program, which is one of the largest and most comprehensive CMS initiatives to tie payments to performance. I will talk about the outcomes that are targeted by the program, as well as about the range of financial implications under the program. And in the second part of the presentation, I will talk about the role of nurses in optimizing hospital performance ratings. And I will wrap up with a discussion of some of the evidence-based approaches that can be used to leverage nurses in improving hospital performance. I'm not sure how many people tuned into the webinar that Rich Lindruth gave 2 weeks ago. These two webinars are very intrinsically related because they're both focused on value. And the webinar that Rich led was focused on the definition of value, which is very critical to healthcare reform. The definition that is being used increasingly more and more often in the context of healthcare reform is that of economic value. And economic value is different from your everyday definition of value because it takes into account both outcomes and costs. So that only interventions that achieve the best outcomes at the lowest cost are considered value creating, as well as interventions that achieve cost reductions without sacrificing outcomes. Interventions that improve outcomes and improve costs a lot are no longer considered to be value creating. So this emphasis on cost is very important because it directly ties to improved outcomes and efficiency, which are both key elements of healthcare reform. Now, the common day-to-day definition of value only accounts for outcomes and does not include costs. So I think the emphasis on cost is something that we always have to constantly remind ourselves about until it becomes the part of the overall healthcare culture, which I don't think it is at this point yet. Hospitals obviously are a large share of healthcare expenditures in the U.S. For example, Medicare spends about 25% of their total spending on hospital payments. So to improve quality as well as efficiency for their beneficiaries, CMS recently implemented 3 large-scale incentive-based programs for hospitals. Value-based purchasing program is the flagship incentive-based program. Hospital acquired conditions reduction program is the other one, and hospital readmissions reduction program. The theme that unifies all 3 of these programs is that they all tie Medicare reimbursement to outcomes and costs of care. This specific talk will focus on the value-based purchasing program. Rich Lindroth and I are actually working right now on a policy brief that will focus on all 3 programs and highlight them side by side and talk about the role of nurses and incentives created by the intersection of those 3 programs. But this particular presentation will focus on the value-based purchasing program only. So to conceptualize the contribution of nurses to the outcomes targeted by the value-based purchasing program, I will focus today on a set of nursing quality indicators that are endorsed by the National Quality Forum and are compiled currently under the National Database of Nursing Quality Indicators, or NDNQI. So the plan is to focus on the intersection of the set of outcomes targeted by the value-based purchasing program and the set of outcomes that are nurse sensitive and therefore can be influenced through high-quality nursing care. So the conceptual framework is, like I said, it revolves around the intersection of the CMS targeted outcomes, which are indicated here as the red circle, and the NDNQI nurse-sensitive outcomes, which are indicated as the blue circle. This intersection of the 2 circles will tell me conceptually which outcomes can influence hospital performance ratings and are in turn themselves influenced by nurses. Once I identify these outcomes, I will review evidence-based care processes that are specific to these outcomes. And then I will talk about the role of nurses in adoption and adherence to these processes. Of course, the contextual influences of structural variables that surround and envelope care delivery processes are also very important, and we will talk about those as well. So the value-based purchasing program, basically what it does is that it rewards hospitals with incentive payments. And those incentive payments based on either the hospital's performance or improvement in performance relative to baseline. The way that the hospital's performance is measured under the program is very much based on a set of quality measures that are already reported and have been reported for a while under the hospital inpatient quality reporting program. However, not all of the outcomes that are included in the hospital inpatient quality reporting program are also included in the value-based purchasing program. Under the value-based purchasing program, the hospital performance score is calculated based on 4 performance domains: process of care domain, patient experiences of care domain, outcomes and safety domain, and the efficiency and cost reduction domain. So I will go over the contribution of each of the domains to the hospital's performance score one by one. So the process of care domain currently includes 15 individual measures. So the table you see on the screen is a snapshot with just a few of these process of care measures as an example. It also includes sort of the evolution of this domain, showing the measures that were included last year, fiscal year 2014, in the first column, this year, and up to what is currently proposed for years 2017 and 2018. You see that the set of processes of care measures is pretty dynamic. Some are being removed and new measures are being added. But mostly measures are being removed. So the processes of care domain is actually shrinking. To illustrate it better, I also included the weight of the entire domain of in the total hospital performance score. So in 2014, this domain counted for 45% of the total score. Almost half of the hospital performance score under the value-based purchasing program was based on the processes of care domain. This weight has been reduced to 20% in 2015, and as you see, it is projected to the plan is to reduce it further to 10% in 2016 and 17. And currently, the plan is that in 2018, the processes of care domain will completely phased out. And if you notice, the weight domain for the 2015 is missing, and it will be missing in all of the domain tables that I will be showing you, because we just do not know what this weight will be yet. The patient experience of care domain currently includes only the HCAHPS survey, and it's included as a composite score of all 8 of its subscales. In the future, we expect an addition of a 3-item care transition measure, which will then also count as a single composite measure, accounting for about half of the total contribution of this domain to the performance score. The domain weight now is 30%, and it is expected to stay pretty stable, maybe diminish a little bit, only slightly in the next several years, to 25%. The third domain included in the hospital performance score is the patient outcomes and safety domain. And right now it includes 3 30-day mortality measures: AMI, heart failure, and pneumonia, as well as central line-associated bloodstream infections. And I will refer to these as CLABSI, and the patient safety indicators. And that's the PSI 90 measure. PSI 90 is included as a composite measure, but it is calculated based on 11 separate outcomes, like things like pressure ulcer rate, post-op hip fractures, and respiratory failure, and things like that. Interestingly, I should note that CLABSI is also included as one of the PSI 90 components. So hospital performance on CLABSI is included as an individual measure in this domain, as also as a subscale in the PSI 90 measure. Next year, the set of outcomes will also include catheter-associated urinary tract infections, which I will be referring to as CAUTI, and surgical site infection. And the weight of this domain is now 30%, and it will increase to 40% next year and after. And the last domain is the efficiency and cost reduction domain. Right now, it only has Medicare spending per beneficiary in it, but it accounts for nearly 1/3 of the total hospital performance score. In the future years, the weight of this domain will go down slightly to 25%, but it still is a big chunk of hospital performance. About 1/4 of the total hospital performance score is put on this particular domain. So as you probably noticed, if you look at the evolution of the domain weights over time, the process of care domain is becoming less important, and the outcomes and safety domain is becoming increasingly more and more important. So what I have shown in this chart here is the relative weight of each of the domains over time, with the process of care domain being at the bottom in blue, the patient experiences domain being the second one in the stack, and it's in red, and the most interesting domain, outcomes and safety, is in green. And you see clearly that the processes of care domain is shrinking, the outcomes and safety domain is growing, and another domain that is going to weigh very heavily in the hospital performance score is efficiency and cost reduction domain. So this reflects the philosophy of sort of the overall healthcare reform to reward healthcare providers based on outcomes and not processes of care. The process of care domain, like I said, will be completely removed from the performance matrix by 2018. So I'm going to talk a little bit about how the hospital performance score is computed. The process computing the hospital performance score goes measure by measure, and the hospital gets a point if they are either above the median on the measure or their improvement on the measure is above the median improvement. And that's relative to an average hospital. Among the participating hospitals, there are about 3,000 hospitals that are currently participating in the program. And that is also adjusted for patient mix. So if your hospital is in the better half, you get a point for that measure. If your hospital is in the lower half, but your improvement is on the higher side, then you get a point for that measure. The only way not to earn that point for the measure is to be below the median and not improve much for that measure. So then the points, after the points are assigned, they're added up for each of the domains, and then the domain weights are applied, and that gives us the total hospital performance score. So the way that the program operates, what makes it solvent or cost neutral is that first all of the participating hospitals pay in 1.5% of their base operating DRG Medicare payment for all Medicare discharges. These are called reductions, and they're then pooled into the incentive payment pool. The incentive payment pool is then used to pay hospitals with payment increasingly higher based on their performance. So basically, the performance scores are linearly transformed into the incentive payment percentage. So that the lowest performing hospitals get nothing, they get a zero incentive payment, and the highest performing hospitals get twice as much as what they paid into the program. This creates, for the 1.5% reduction, this creates an incentive range of negative 1.5 to positive 1.5%, or a 3% differential between the two performance extremes. This difference will be increased to 3.5% in 2016 and to 4% in 2017. So again, you're seeing this increasing commitment of the CMS to reward and punish hospitals based on their performance. So I wanted to give you a quick illustration of how the value-based purchasing payment adjustments are computed. So like I said, first all of the hospitals are docked about 1.5% of their base operating DRG payment. Then based on the hospital performance scores, some of the hospitals all of the hospitals receive a little bit of a payment. Some of the hospitals get more, some of the hospitals get less. If you see on the left here, the hospitals that are in the poorest performing range, their value-based purchasing program incentive payment is very small, and hospitals at the top of the performance range, their incentive payment is quite large, and in fact it is twice as high as the 1.5% that they have contributed to the program prior to their performance being evaluated or measured. So then when you subtract from this incentive payment the original payment reduction that hospitals had to contribute, what you have here in black is the actual value-based purchasing payment adjustment. And if you just focus on the value-based purchasing adjustment, that's the thing that's the actual either penalty or incentive payment that is applied to hospital DRG payments under this program. And it ranges from negative 1.5 to positive 1.5 with the effective incentive differential of 3%. In 2015, if you look at the incentive, at the distribution of the value-based payment adjustments, about half of the hospitals, maybe a little bit more than half, received a positive payment. About half of the hospitals received a payment that didn't quite cover for their original reduction in the DRG in the Medicare payment, and the range here should be between negative 0.5 and positive 0.5, but the CMS actually acknowledged the fact that the data that they have released might have had a slight miscalculation of the upper range because it goes to a little bit over 2%. So they are now working on trying to figure out what is going on with their formula. It should be between -1.5 and +1.5. But that is the actual distribution of the value-based purchasing payment adjustments as computed at this point for the fiscal year 2015. So now we will move on to the discussion of how nurses can be leveraged to improve hospital performance ratings. And to do that, we're going to look at, like I said earlier, the intersection of NDNQI, nursing sensitive indicators, and outcomes included in the hospital performance score under the value-based purchasing program. And there are 4 outcomes that lie at that intersection. And those are CLABSI, CAUTI, pressure ulcer prevalence, and ventilator-associated pneumonia. In the next few slides, I'll go over those outcomes one by one and discuss their contribution to the hospital performance score. So CLABSI, or central line-associated bloodstream infections, they're included directly in the outcomes and safety domain, as currently one of only 5 outcomes. So then, given that the weight of the entire domain is 30% in the hospital performance score, CLABSI contributes individually 6% of the performance score. Additionally, it is also included as part of the PSI 90 indicator. So the patient outcomes, so that it increases its weight in the total hospital performance score to 6.55%. Next year, as the CMS adjusts and changes the set of outcomes that's included in the hospital performance score, the weight will go down to 6.23%, but it's still a pretty large chunk of the overall hospital performance score. CAUTI is very similar to CLABSI, with the exception of the fact that they are not included currently as part of the PSI 90 index, and therefore their total weight is 6% of the hospital performance score under the value-based purchasing program. And next year it's going to go down again slightly because CMS is adding more measures, so the weight of each particular measure is diminishing, but it still is a very high percentage. When we look at the pressure ulcer prevalence, it is not included as directly as one of the measures targeted by the value-based purchasing program. However, it is a part of the PSI 90. And as such, it's one of the 11 outcomes that go into calculating the patient safety in the PSI 90 composite score, and therefore, that PSI 90 contributes about 6% of the weight of the hospital performance score. So as such, as part of it, pressure ulcer prevalence contributes about 0.5% to the hospital performance score, and that's going to go down slightly in 2016. And the ventilator-associated pneumonia rates, again, they're not directly included in the value-based purchasing program. However, they are related to 30-day pneumonia mortality rate. And in fact, ventilator-associated pneumonia contributes about 13% of all mortality cases, of all 30-day pneumonia mortality cases. And that is an individual, and the 30-day pneumonia mortality rate is an individual indicator in the outcomes and patient safety domain. So although it is difficult to establish an exact relationship between ventilator-associated pneumonia and mortality and the weight of this outcome in the hospital performance score, there's clearly a link. So to summarize, what outcomes should be targeted by nurses, or what outcomes should be targeted if nurses want to be leveraged as a way to improve hospital performance? Clearly, CAUTI and CLABSI are very important. They together account for over 12% of the hospital's performance score, and they should be the primary focus. Pressure ulcer prevalence and ventilator-associated pneumonia are also important and should be clearly looked into. So where are we now with regards to those outcomes? What we know is that there are very well developed hospital-acquired infection prevention bundles. There is one that's been developed and well tested for CLABSI. There is one that has been developed and tested well for CAUTI, and there is a set of evidence-based practices for ventilator-associated pneumonia as well. And they have been very successful in reducing the rates of those hospital-acquired conditions, up to 40% for CLABSI, 40% for ventilator-associated pneumonia, and 6 to 14% for urinary tract infections. However, a recent survey found that the adoption and adherence to those bundles is very low. In particular, CLABSI sort of leads the pack with 87 to 97% adoption and 37 to 71% adherence. Ventilator-associated pneumonia, about 70 to 90% adoption and 45 to 55% adherence. And urinary tract infections are the lowest. Their adoption is only 27 to 68%, and the adherence is only 6 to 27%. So improving adoption and adherence to hospital-acquired infection prevention bundles seems to be one of the clearest ways and one of the most important strategies to target as a way of improving hospital performance and those outcomes. What can we do to improve? A recent AHRQ report that looked at the adoption and adherence to those bundles among hospitals found that there are several key elements, several key strategies that hospital need to ensure, make sure to have in place are educating all physician and nursing staff on evidence-based practices, empowering nurses to ensure compliance with checklists that are developed for each one of the conditions, and also providing feedback on infection rates at the nursing unit level. I'm missing the word unit here. I apologize for that. So the two sort of threads that were common across different types of bundles and adherence and adoption to those bundles, and they were particularly important to adherence to the evidence-based practices, was ensuring that the ownership of infection rates and the knowledge about the infection rates was shared between infection prevention specialists who traditionally own that domain and other clinicians responsible for patient care, such as physicians and also nurses. And another key element that was very critical to adherence to those practices was that hospitals had in place what they call physician and nurse champions. And those were the people who were advocating for creating the culture of adherence to those practices among the nursing staff and the physician staff as well. Physician champions were critical to empowering nurses to intervene when they saw a breach in practice or a breach of the protocol where practices were not being followed. Of course, we can't just to improve processes of care. We have to make sure that the structure within which the processes of care are nested is also supportive of those improvements. And some of the structural elements that have been critically important for measuring the quality of nursing care are nurse staffing, and that's nurse hours per patient day, nurse skill mix, and that's the proportion of hospital nurses that that are RNs, that are registered nurses versus supports versus non-RNs, and as well as nurse education, and that is usually measured as the proportion of hospital nurses with a baccalaureate degree and above. Those components of nursing structure, factors describing nursing structure, have individually been shown to improve outcomes, patient outcomes, and those outcomes are 30-day mortality, pressure ulcers, lower costs of care, lower failure to rescue, less medication errors, and there's a large body of literature that shows that those outcomes, improvements of those components of nursing structure, descriptors of the nursing structure, are very important for improving patient outcomes. But they're also important for creating an environment where processes of nursing care that target the particular outcomes that are important for the value-based purchasing program are being followed. Work environment is another important element of nursing structure, and that includes various domains that describe collaboration between physicians and nurses, opportunities for nurses to participate in hospital and unit level decisions, and a nurturing environment for continued nurse education. And again, work environment, better attributes, better work environments have been linked to an array of improved patient outcomes, reduced mortality, lower costs, failure to rescue, and other outcomes that we would wish to improve. And they also are associated with reduced nurse turnover. So improving nursing structure appears to be a very important element to ensuring that the processes of nursing care that are associated and important for improving hospital performance are being implemented. So in conclusion, I wanted to bring that same diagram that I started with in the beginning of the presentation, and I wanted to sort of put some of the things that we talked about in the circles, so replacing the blank spaces that we had there before. So the 4 outcome measures that are at the intersection of nursing sensitive outcomes and the set of outcomes that are targeted by the value-based purchasing program are CLABSI, CAUTI, pressure ulcers, and ventilator-associated pneumonia. The process of care that seems to be important to improving those outcomes has to do with increased adoption and adherence with hospital-acquired condition prevention bundles. They have been developed and tested for those specific conditions, and they have been successful in reducing the rates of those undesirable hospital-acquired conditions, but are not currently well adopted and adhered to. It's important that nurses feel empowered and are empowered, that processes are put in place and the culture is developed around empowering nurses to feel like their contribution to those processes is important, and also to make sure that nurses feel comfortable intersecting physicians when physicians may not be following those processes of care exactly. And it's also important that the physicians understand that that role of nurses is critical, and they are encouraging and empowering to the nurses to take upon this role. It is important that the ownership of the knowledge and the responsibility for hospital-acquired infections is shared to the degree possible between the infection prevention specialists and physicians and nurses. That has been also, like I said, it has been proven to increase adherence to the evidence-based bundles. And the structure within nursing processes are embedded, characterized by better staffing, better skill mix and education, and improved nursing work environment, has to be in place to ensure that nurses are participating and contributing to the processes of care to improve those outcomes. So it appears to be that the formula for success in leveraging nursing to improve hospital performance under the value-based purchasing program consists of 3 key components. First, focus has to be placed on outcome-specific evidence-based nursing interventions. That has to be accompanied by investing in training and education of nurses so that they can understand and implement evidence-based practice. And it also has to be, a successful hospital also has to be committed to a positive nurse work environment so that nurses can positively contribute and feel ownership of processes of care and outcomes of care that are important for the hospital's success under the performance-based programs. So that concludes my presentation. And we have about 20 minutes for comments. I feel like I skipped half of my slides. I probably didn't, but I feel like I did. So if I went a little bit too quickly, which I sometimes tend to do, please feel free. I'll be happy to go back to some of the slides that might not have been clear. Peter, Christy?
Great. Thank you, Olga. Appreciate it. At this point, we are going to open up to questions, as Olga mentioned, from the audience. So please use the questions area of the GoToMeeting toolbar to enter your question, and we'll pose as many as we can to our presenter. I always like for Peter to lead us off with a question if he has one he'd like to pose to Olga. Peter?
Yeah. Hey, Olga. Thank you very much for your talk. It's very, very rich, and I'm glad that we will be able to post your slides on the our website, because I know I'm going to go back through your slides probably several times to get the full amount of information here. But one thing I was sort of wondering is that we've also got this new change in physician payment that is now replacing the sustainable growth rate, the tie-in of the growth of the SGR to physician payment, to a new payment system that will be based on, I think, 4 different items. And if I can remember, one of them has to do with the resource use that a physician uses. One has to do with the quality of care in terms of an outcome that's measured. Another has to do with whether or not the physician is using and involved with electronic health records. And the 4th aspect of their new payment system involves whether physicians are involved in quality improvement projects. So 4 things now that are going into the new payment system. Now that's our physician colleagues. Have you had any chance to think about how that new payment system will it transfer over to nurses?
So I think it is very difficult to establish direct links between the between physician performance and sort of nurse contribution to hospital performance, because there is another thing. Nurses are not incentivized at the nurse level, at the individual nurse level. So their incentives are sort of trickling down through hospital performance matrix. And that makes it a little bit more difficult to directly line up with physician incentive programs. What I can say is that there are some common themes in sort of hospital performance incentives and physician performance incentives, and those themes are the emphasis on the quality of care, the emphasis on reporting the outcomes of care. And I also wanted to note that resource use domain under the physician reimbursement program is also going to be diminishing. The plan is to phase the resource use domain as well, to phase it out and put more emphasis on the quality of care and quality improvement and reporting of outcomes. And so to the extent that physicians are making a connection between the importance of a collaborative relationship with the nurses and how that imputes into the outcomes of their patients, I think that is to be seen, right? Because that's how you would see that impacting nurses. Is physicians feel that nurses are important to the ultimate success of their own performance, then this will change something for the nurses. Otherwise, it might not. I guess that's something that remains to be seen. That this incentive-based program is a very or incentive-based payment models are a very comprehensive sort of drive, and it's a huge part of the healthcare reform. A lot of them are unrolling gradually, and more of them are added in, and how that all impacts care and patient outcomes and population health and access to care, which are the goals of that reform. I guess we'll have to live and see.
Yeah, fair enough, Olga. And I like how you're connecting that, the outcomes that the good improvements in outcomes that physicians are needing to be accountable for, to the extent that that involves nurses. Maybe that's a good way to be thinking about how the link between the payment reforms for hospitals will interface with what's going on with nurses who are working in hospitals. So just while I've got you on the microphone, Olga, what advice would you give to nurses who are beginning to, turn on to this idea of value, beginning to say, maybe this isn't a fad, maybe this is something really important. I'm hearing so much about it. What would you say to them, those that are working in hospitals?
So I think a very important thing that every nurse has to understand or appreciate is the fact that every nurse has an individual impact on patient outcomes. And I think that's something that a lot of times gets overlooked. First of all, sort of the nursing philosophy is very much team-based. And the individual contribution of nurses to patient outcomes is not something that we typically talk about. We do not reward good nurses. We do not always know who the good nurses are. There's no way of sort of rewarding or identifying or incentivizing good nurse performance. But individual level nurse performance matters in very meaningful ways, and that's something that I think every nurse has to understand. When she lays her hands on a patient, it's not that she is contributing a great grain of rice to, to a big bucket, and it doesn't matter. It does matter, and we have seen it in some of my own work. We see the individual contribution of nurses to patient outcomes being very, very, very important. And whether or not at any point in the future healthcare reform will catch up to sort of recognizing the individual contribution of nurses, we do not know. But it's there, it's real, it's important, and nurses have to take pride in their work and have to understand that they matter. Each one of them matters.
Thanks, Olga. Christy, do I still have the microphone, or are you ready to switch to someone else?
We actually had a question, and as you were talking, in thinking about data and how we're going to measure these outcomes, do you think we're there in terms of data needs for measuring these on a broad scale, or is there more work to be done, or what do you think on that note of how are we going to measure these outcomes and things?
Christy, are you asking at the level of the hospital, at the level of the unit, or at the level of the individual clinician?
I'll let you go with whichever one you would like to answer.
So I think at the level of the hospital, these outcomes are picked out of the set of outcomes that has been reported since, 2007, I think. So it's been, I'm not sure about the year, but this hospital quality reporting program has been in place for a while. The outcomes are out there. There's the Hospital Compare online website where you can go and look at hospitals, compare them side by side based on those outcomes. And the measures may not be perfect. For instance, pressure ulcer prevalence is one of the ones that is very commonly I don't want to say underreported, because that sounds like hospitals and units are doing that on purpose, but it's just not very, it's not very accurate. So there are measurement problems, but I feel like at the hospital level, the outcomes are pretty well, the measurement of these outcomes has been developed the best. At the unit level, measures are not as well designed, developed, and reported. And in fact, I don't think sometimes units know what their performance on those matrix is relative to other units, which is oftentimes not relevant for the hospital, but it would be interesting, I think, for units to be able to compare their performance with a similar unit in another hospital. We're not doing this at this point, but I think that's one of the steps that could be done in the future. At the individual provider level, we are not there at all. I think there's got to be a way of doing this, and I have piloted some of those individual level, sort of clinician level individual measures of performance based on patient outcomes through the electronic health records, but it is really, really messy right now, and it requires much further development. So I don't know if I answered your question. At the at the high level, those measures are pretty well developed and okay. At the unit level, they're not as good. At the individual provider level, they are, or especially for nurses or hospital-based providers, they're not there.
Yeah, I think you did answer the question. That was a great insight into that. I have another question that's come in. Have you considered putting together a comment for the recently released request for information from CMS on merit-based incentive systems?
Christy, you broke up a little bit. Could you repeat this, please?
Sure. They're asking, have you considered putting together a comment for the recently released request for information from CMS on merit-based incentive systems?
I think it's interesting that you know this. There is a lot of new things and proposals and policies that are in development, and I didn't plan on commenting on that one unless Peter asks me. But at this point, this wasn't on my on my list of things to do. But I that somebody will do it. I think it is an important area, and there are policies are being developed without well, I shouldn't say without proper vetting, but it's hard to account for all of the possible consequences. So I think that's a valid question. I haven't done anything about this myself.
Okay, great. And then I have a housekeeping question. I think Peter alluded to the fact that you would make the slides available. I have a few people asking about the slides being available. Will we be able to post those on our website?
Absolutely.
Okay, great. I have one more. The comment here. APRNs occupy that middle ground and can earn individual incentive payments if only Congress pays attention. No APRNs were included in Medicare EHR incentive payments. Only midwives are excluded from the MIPS, the Merit-Based Incentive Payment System. Do you have any comment further on this individual's comment?
So I think there are two things. I could comment at it from two angles. Advanced practice nurses is sort of that. I feel like it's the part of the healthcare workforce that has the most potential and the least sort of leverage relative to their potential right now. So I think potential value in further expanding the scope of practice and incentivizing and rewarding advanced practice nurses is huge. I think there's a lot of politics involved in there, and I'm not going to touch upon that right now. And I'm pretty sure that there's a critical mass of people, and I know some of those people personally, who are working on those exact issues and on sort of tilting the policy more towards recognizing and rewarding advanced practice nurses. But one of those things where it's a very high value dimension, a lot of potential there. Let's hope that healthcare reform does move that way, but it's hard to tell.
Okay, great. Peter, I think you had one more question.
Yeah. Olga, first of all, thank you very much for giving our webinar today. And secondly, thank you for all the good research that you are doing and have been publishing over the past several years. I think you and Rich and a few others are really sort of breaking down some of the empirical and conceptual issues that we will increasingly be thanking you for as the whole value-based world develops. But I have one other question for you, and I hope that you'll be able to pause and answer this, but you have done a fair amount of research that's been published, and I wonder if you could just tell the audience maybe 2 or 3 findings that you feel are important and why they're important to you. And here's your opportunity to sort of shout that out to a number of people across the country.
So I started a lot of my research as a skeptic, and by the time I convinced myself that something is true, I feel like I can convince others. So the 2 things that I'm very convinced of is that A, nurse education does matter in important ways for patient outcomes, and I know that this has been a very well-developed field, starting with the work of Linda Aiken, that looked at hospital-level comparisons, but I feel like there is still a little bit of an area there for doubt, because when you compare hospitals based on the proportion of their nurses with a baccalaureate degree and patient outcomes, there is so much under the hood in those comparisons that it becomes very difficult to attribute, well, it's not difficult to attribute a difference in patient outcomes to better or improved patient outcomes to better education, but I think there's a lot of room for skepticism there. So one of the works one of the projects that Rich and I have been very involved in is trying to look at the value of nurse education to patients, or the importance of nurse education to patients, after removing all of those potential differences across hospitals. And what we did was we looked at one specific hospital and we looked at patients in that particular hospital, and we tried to see, so we were able to link patients to all of the nurses who provided care to each of the patients over the course of their hospitalization through the electronic health records. And then what we did is we said, okay, so if nurse education matters, then patients who were taken care of by nurses with more education should be doing better. Right? If it's not hospital level differences, it's not patient case mix, if it's not all of those things that call for skepticism in hospital level analysis, then when we look at patients who are side by side hospitalized for the same condition in the same unit at the same hospital, when we compare them, and if we see the patients who were taken care of by nurses with more education do better, then that is a clear case for the importance and the positive contribution of baccalaureate or higher level education in nursing to patient outcomes. And we did find that. When we compared patients side by side while controlling for a lot of things, patients who were taken care of by more nurses or who had more highly educated nurses on their, among all of the nurses who take care of them during the hospital stay, they did better. Their costs of care were lower, their readmissions were lower, they were less likely to die. So to me, that was clear evidence of the fact that nurse education matters. Now, why it matters, we're not really exactly sure. Is it that educating nurses makes them better providers of patient care, or is it that nurses who are better providers or who are more diligent, attentive, have better attitude, have better personalities, they're more likely to get an education? We do not know. But at least we clearly see that nurses with more education provide better care. Their patients' outcomes are better than nurses who do not have a baccalaureate degree. I think that was one of the more convincing arguments and one of the more interesting results that came out of some of my work. Another thing that we did is we looked at outcomes of nurses. Again, we looked at nurses in the same hospital, and now we did the other type of analysis where for each nurse we looked at all of the patients who the nurse took care of over the course of a 6-month period. And then we used the outcomes of those patients specifically tied to each individual nurse to sort of create kind of like a version of this value-based purchasing performance score, but for nurses, for individual nurses. So that was like a thought experiment. Let's play with some data. We're economists. We don't have to, we don't have to really, we can play with the data. So we did that, and we found that there was a very significant large distribution, even among nurses in the same unit. There were nurses whose patients were on average doing better, and there were nurses whose patients were on average not doing so well. We're also able to link those differences in performance to education. Once again, the link to nurse education, where better nurse education was associated with having a higher performance score relative to your colleagues. We also linked it to expertise level. Again, higher nurse expertise level individually was also associated with improved nurse performance. But the most interesting thing that came out of that work to me was that differences in education, expertise, experience, all of those things that we typically think are very important as in describing a nurse, were contributing very, very little, only 8% to the differences in what we estimate in our estimates of the performance scores. So it seems, after this work, it seems to me that nurse performance matter, and it seems that there are nurses who are good, there are nurses who are not so good, but what explains those differences really is a mystery. It's not education, it's not experience, it's not expertise. It seems to be something that we're not measuring, not observing, not rewarding, not focusing on, but it matters in important ways. So in my future work, I plan on trying to explore that unexplained part. What is it? What is it about nurses that makes them better performance? What is it about nurses that makes their patients have better outcomes? We don't know. Education is part of it. Experience is part of it. Expertise is part of it. But a huge part of it is something we do not know. Sorry, was it too long?
No, that was perfect. That brought us right up to time. So I want to go ahead and say thank you so much, Olga, for agreeing to present today, and I can probably speak for everyone in saying that was a great presentation. We want to thank the audience and everyone who attended today, and we hope that you will save the date for our next webinar presentation with Dr. Richard Holden. He's an assistant professor at the Health Informatics Department at Indiana University, Purdue University, Indianapolis on Wednesday, November 4th at 2 p.m. Eastern Standard Time, and we hope to see you all there. Thank you so much.
Thanks, guys.
Thank you.